We now call them paramedics. They are the upskilled, highly trained AMBOs of Victoria's Metropolitan Ambulance Service. Let's go behind the scenes and find out a little bit more about the revolutionised AMBO of the 21st century.
The two levels that we have in MAS at the moment are ambulance paramedics and MICA paramedics. MICA, of course, standing for Mobile Intensive Care Ambulance. A MICA paramedic can do a number of very invasive procedures in the field that ambulance paramedics can't, and the number of drug regimes that they can implement in the field with patients is also quite extensive. Ambulance paramedics perform a job to a certain level, so they perform a large number of patient care modalities, drug administrations, procedures, and then for potentially or actually life-threatening patients, intensive care paramedics can come along and take that level of care from where the ambulance paramedic stops and take it that next level for heart attacks, anginas, AMIs, cardiac failures, any severe respiratory such as asthmatic patients, COPD, anything which compromises an airway, major trauma, so car accidents where there's a multi-trauma situation or a trapped patient. You'll find that MICA paramedic units are sent to those. Many of the drugs that MICA paramedics carry aren't carried on the standard ambulances. Some of those are furosemide or Lasix, which of course we treat for acute pulmonary edema, cardiac failure. We also carry a number of antiarrhythmics such as verapamil, aramine, which we use in the treatment of SVTs pre-hospital. Midazolam, diazepams, morphine, some of those drugs you'll find that aren't carried on the standard ambulances and again are crucial in treating patients in the field and ultimately saving lives, which I guess is our goal. So MICA paramedics can perform a number of very invasive procedures in the field without obtaining authority or authorisation from a receiving hospital or doctors, etc. Some of those procedures is intubation, which is our primary level of airway maintenance for patients that need it, as in cardiac arrest or severely head injured or any life-threatening situation whereby the patient has an unequivocal life threat due to airway compromise. We can intubate the patient accordingly. MICA paramedics can perform synchronised cardioversion, which is up on top of standard defibrillation. We can insert intraosseous needles with paediatric patients in the field as well, so whereby you've got small babies where intravenous cannulation is impossible due to the fact of they've got very underdeveloped veins. We can then access or give them fluids and drugs via an intraosseous needle just straight into the bone. MICA paramedics can also perform the insertion of a pneumocath in the field as well, so patients that suffer tension pneumothoraces can be relieved in the field with the insertion of one of these pneumocaths, and that has been proven to be time and time again a life-saving procedure which is vitally important and has been used on a number of occasions and has saved many, many lives accordingly. MICA paramedics are very much first-line, full-on emergency physicians in the field prior to arriving in hospital. The procedures that they can carry out, the drugs that they carry, what they can do in the field is quite extensive. Very, very important to the maintenance of a patient's well-being, and yeah, certainly it's a very first-line level of care which we introduce into the field. It's like bringing, I guess, a large part of the hospital emergency department into the home. One member of another emergency service said to me, he looked at me one night and he said, "You've got a front row ticket to the best show on earth." And I thought that was a very interesting comment to make. Yeah, we do see quite a wide variety of things, and I guess you become less shocked as you're in the job for longer periods of time, but you do certainly get greeted with different scenes and scenarios just about every time you go out into that car, so you've got to keep an open mind.
Stand clear.
Just going to do a defibrillation in the back of the vehicle. Okay, 360 is ready, stand clear, and away we go. Just let that settle down. Basically, yeah, it's a very uncontrolled job that we deal with, generally speaking, and I guess that's one of the beauties of the job is, firstly, you don't know what you're going to go to every shift, and secondly, when you do, you're going to manage it very, very differently, and you're going to have to make some very quick decisions at the time. One intubation I did, which sticks out in my mind, was of a patient that was trapped in a motor vehicle accident who required intubation there and then, and I was able to do that at the scene, but what made it very, very challenging was because he was actually trapped in the scene. He was sitting upright. We couldn't move him into a perfect position from what you'd normally find in a hospital or laying flat on the floor or a bed. So I actually had to have the roof of the car actually removed, and I sort of straddled him from behind and used the laryngoscope, etc., looking downwards rather than flat on a bed to actually intubate him. It was challenging, but we got there in the end with a number of adaptations to various procedures, which paramedics are trained to do, just adapt to the situation at the time and go in, address it accordingly and deal with it.
So, okay, tubes in, good waveform on the capnograph. Okay, and we've got an output again.
Oh, look, being a MICA Paramedic, it's just, there's a lot which makes it a very appealing position to hold. I think, as I said, there's no certainty as to what sort of cases you're going to be called every day, and generally speaking, you're only called to the potential or actually life-threatening cases, the ones that require you to make some very quick decisions, use a number of your procedures, use a number of your drugs that you wouldn't normally use on everyday cases. That's certainly very, very appealing, very challenging. And I think too, just you're being called into these people's lives, into the public's lives at what is crisis level for them. They've called you because a member of their family has excruciating chest pain, for example. Now that's a crisis point in their lives, and they're turning to you for help and guidance to look after their relative. So that is also very rewarding in itself.
Let's just slow down a bit. Okay, now you're able to... Hello guys and girls.
This is David.
Hello David, I'm Lindsay. In a nutshell, arrest with no prior symptoms, multiple shots.
A male in his early 70s was attending a pub in Richmond, and I'm told that he'd gotten up to make a speech and had to step back down again after the speech and just simply collapsed unconscious. No complaints of anything prior to the collapse. Some family members and friends then put a couple of anginine tablets under his tongue whilst he was unconscious on the floor. The first crew from Richmond, the Richmond paramedics, arrived first and assessed the patient, found him to be in cardiac arrest in VF, and they defibrillated him twice, which put him into asystole. I've then arrived and continued on the case from there. The first thing I had to do was secure the patient's airway. He had a very, very soiled airway. There was just a very large amount of vomit which required suctioning, so addressed that and intubated the patient accordingly. Gave the first dose of adrenaline actually down the tube because it was still another minute or two before I could get an IV access in. So the first thing we did was pop in some adrenaline via the ETT tube. I then established IV access through the right external jugular vein with a 16 gauge and set up some Hartmann's fluid and continued with the adrenaline increments through that. Sodium bicarbonate and lidocaine, because it was basically a refractory VF scenario. He'd go from VF, asystole after some defibrillations, back to VF, and this just went on and on. And then once we actually loaded and started heading to hospital, we actually got, or prior to loading, we actually got a heart rate back, so the patient did have an output with a blood pressure of 80 systolic. During transport we lost it, did some more CPR, gave some more adrenaline, fluid administration, and kept getting it back, kept losing it. So it was a bit of a seesaw all the way in. We transferred the patient over at St Vincent's Hospital in the resus cubicle, as you saw, and unfortunately the patient has subsequently passed away.